Test 1 2 1 2 1 2 1 2. Testing, testing, testing.
About myself, I'm actually from the East Coast, but I trained in California, so now I'm a practicing internist out of San Francisco. But interestingly, most of my career I spent as being a medical director of either a hospital, an integrated healthcare network, a healthcare plan, and then even a medical information system company. And most of my work as a medical director was dealing with other physicians and clinical staff on being compliant with what's happening in the healthcare environment. So when you're a medical director of a plan and you're talking about physicians about appropriateness and necessity, you really get to understand physician attitudes and behaviors. And of course today I'm going to talk about stress and burnout and what it can do to individuals. But before I start with all that, I look at physicians and all healthcare professionals as being a precious resource. I think we're all in it for the good of trying to provide best patient care, but there's a lot of distractions, a lot of pressures internally and externally that tend to interfere with what we do. So a lot of what I'm going to talk about is what's happening, but most importantly I'm going to talk about what and we is not just the individual physician or the pharmacist or the nurse. It's what our organization really has to do to try to help better understand some of the issues that we're facing and to provide the support services to enable us to better adjust to the pressures so we can succeed. There's a lot of information in this particular session. You do have copies of the handout. I have my contact information at the end of the handout, so if you would like more information or talk to me, certainly you can ask questions. Feel free to do that, because I'm really here to try and help. So just to get started, the title is The Frequency and Impact of Physician Stress and Burnout. I'm also going to talk about stress in other professions as well, what we need to know and need to do. I'm going to start off by just reading some quotes from Malcolm Gladwell, and he talks about the duality of being a doctor. Most physicians go into medicine with a mission-driven spirit. They're committed to helping people. That's why we all do it. They're grateful for the opportunity to care for others. They're proud of their ability to diagnose and treat, and they're inspired by the trust their patients put in them. I'm reading this in the very beginning because some part of the reaction of helping individuals is to understand why they went into this profession in the first place. In the second paragraph, but those experiences contrast vividly with the economic side of being a physician. Each day, mundane financial tasks distance doctors from the reason they chose medicine as a career in the first place. That's the duality of being a doctor. There's a fulfilling personal side and the frustrating impersonal side. So these will be the learning objectives. Gain a better understanding of the timing, incidence, causes, and impact of stress on healthcare practitioners. Discuss the negative impact of stress and burnout on attitudes and behaviors that can adversely affect care relationships, satisfaction, patient safety, and quality of care. Then learn how to develop effective strategies to address stress and burnout and implement programs designed to enhance professional behaviors, staff satisfaction, and overall well-being. And lastly, to discuss the importance of collaborative strategies for early intervention geared to help healthcare professionals attain a healthier, more satisfying personal and professional life. So I'm not sure how many of you actually read the literature to get an understanding of what's happening in our environment. I'm sure a lot of you feel some of the issues that I'm going to talk about, but some of the prototype studies were done through the Mayo Clinic Foundation and published repeatedly starting back in 2008 all the way up to present day. And this classic article by Dr. Shanafelt and his group are changes in burnout and satisfaction with work-life balance in physicians working between 2011 and 2014. On the right of the graphic, you can see each individual physician's specialty and their degree of stress. So certain specialties, particularly the high-stress specialties, are going to suffer more from burnout and stress, but almost all types of specialties are affected, and it probably affects close to 50% of all physicians. And then the most recent report is the Medscape report, just published in 2018. And again, you can see which specialties are involved, what the symptoms are, But overall, they found that 42% of physicians report significant levels of burnout, and actually 15% of physicians actually admit to being depressed. What are the causes and consequences? Again, if you read those reports, and then they're all present-day reports, what I've done is I've summarized the causative factors into two larger groups. One is bureaucracy and administration, external factors, and the other one is the consequences. So bureaucracy, a lot of us, particularly if you've been in medicine for a long time, there's been a change in focus of what we really should be doing. There's a change in intent. There's different masters and different types of incentives other than best patient care. Some of this has affected our workload, the way we process flow and patient flow, changing roles and responsibilities, more and more administrative hurdles to handle, more and more documentation, more and more non-patient related administrative tasks that we have to complete. There's a greater focus on contracts, there's a greater focus on productivity, there's a greater focus on cost efficiency. There's more and more metrics that we're being held accountable for with reimbursement and satisfaction based on those types of metrics. And certainly the whole issue with electronic documentation and the electronic medical record. Those are all the bureaucratic issues that tend to affect individual physician and other healthcare professions' types of attitudes and behaviors. So what's the consequences? Well, when we're losing control, I'm not autonomous anymore, there's more intrusion, I'm sort of losing my zest and idealism for practicing medicine because now it's becoming more of a business than a quality of care initiative. I'm losing my idealism. I feel like I'm losing respect. I'm losing purpose. As a downside, with more and more physicians are dissatisfied, they're frustrated, they're angry, there's stress and burnout, and then there's real behavioral problems, actually sometimes leading to suicide. And lastly is the impact of care. And all of us are in this business because we want to try to provide patient care. So when you start seeing some of these types of attitudes and behaviors affect patient care, it's an eye-opener to not only the patient, but also to the individual who's providing that care. And very recently, and these are all articles from 2018, 2017 from JAMA, from the Archives of Internal Medicine, from the New England Journal of Medicine, it's talking about the relationship of unhappiness, poor satisfaction, stress and frustration, and the negative impact that this can have on relationships that impact patient care. So it's a very serious consequence when you think of some of the downstream effect. And again, the advantage of having the handouts is you can look for more details in some of these individual articles. Now, what happens when individuals get stressed and frustrated? They become a little bit irritable, a little bit confused, and not thinking the best that they can. So it may affect their judgment, it may affect their decision making, and it may affect the way they communicate with their peers, with the nurses, with the pharmacists, with the ancillary staff, with the patients and their family. So there was a recent, this one is from the Physician Workload Survey in 2018, and we're talking about the signs and symptoms of stress and burnout. So what I try to do is to highlight what some of the red flags are. So either you can look at this as, is this going on in me, or is this going on in a colleague who I'm dealing with, and if it is, then maybe we should do something about it. So you may notice a subtle change in persona. You may notice that they're fatigued or exhausted. They're becoming a little more apathetic, a little more detached. They're becoming irritable. They're becoming more cynical of what they're doing. They're less communicative. They may be becoming angry or hostile. They may be depressed. They may have some emotional liability. I hinted again at suicidal ideation. You may see the physical signs of stress. It may lead to disruptive behaviors, and then it may lead to judgments and mistakes, which is, the worst downstream effect on the patient. So then we ask, okay, what about the coping mechanisms? How are individuals handling all of this? And again, I'll talk about this more in the next slide. I'm circling the issue on therapy. What you're going to find is here 10% of physicians in particular, but maybe others, are reaching out for outside help as therapy, which means 90% are not. And then the question in this particular survey, have you ever met with a mental health professional? Close to 80% have not. So why is that? Well, when you go to a physician, and I'm stereotyping on purpose, I'm not under stress. Yeah, you're right, I'm under stress, but you know what? I've been under stress all my life, and I can handle it. Yeah, I'm going to make more time for relaxation. Oh, excuse me, I'm getting another call. Just wait a minute. You don't understand my world. And you don't even care about what's going on with me. This is outside views on the physicians. And even if they wanted to act, are they aware that they're stressed and burnt out and how it's affecting them? Do they know where to go to for support? Do they have access to those resources to help them? And is the organization actually responsive to their needs and trying to help? And we'll talk a lot about this as we go through. Secondary issue is the whole idea of very stoic individuals, physicians. I mean, you need to be that way. You're dedicated. You persevere through medical school and through training. And then there's the stigma. If you admit that you're under stress or something like that, what are people going to think of you? I don't have the time to pay more attention to this. I don't want to be labeled with a diagnosis that may affect my feelings about competency or credentialing. There may be fears of retribution and concerns about confidentiality. So is this really going on? Again, looking at all these articles that are coming out, again, from the Mayo Clinic Proceedings, from JAMA, from the New England Journal of Medicine, the most prestigious medical journals, it really reports about physicians are reluctant to open up for fear of what the reprisals are. And then in that physician landscape questionnaire, they asked about mental health being a taboo, and really 50% of physicians said, yeah, I don't want to have any issue of label of mental health. So we'll get to how you deal with some of those barriers in a minute. But then let's look at the organization. As I said, you have the individual physician as part of a group, as part of an employed physician or whatever, but they're usually working for an organization. And the issue is the organization aware of what's going on and what are they doing to try to help you? So when you look through all these different surveys, what you find is more than 75% of the time the individual physician says, you know, there's no services available, nobody really cares, my organization isn't doing anything to really help me. And then in this recent article, facility supports a healthy work-life balance. Well, over 60% of the physicians surveyed said they're not. So what are the consequences? So this is both for physicians and staff. You become less satisfied with your job. You become a little more irritable, cynical, apathetic. It may lead to sleep disturbances, which lead to further fatigue, which of course compound the issue. It can have other negative impacts on your physical health. Negative impacts on emotional health, whether it's anxiety, depression, or behavioral disorders. Your performance may suffer, your patient satisfaction may suffer, patient safety issues may occur, and in the end, it may actually affect your career. For the organization, it affects overall culture and morale. It will increase turnover, increase problems with recruitment and retention. There's poor care coordination, impaired productivity and compliance, disruptive behaviors may occur, negative impacts potentially on satisfaction and reputation, negative impacts on quality, and then if you suffer negative impacts on quality, then you have the repercussions of either liability or penalties. So what do physicians want and what do organizations want? Physicians want to provide good patient care. They want to feel good, happy, successful. They want to feel respected. They want to feel like they do have a sense of control. They do want a work-life balance, but they don't make time for it because they're so, foisted on meeting patient demands or administrative demands. And they want administration to try to help them. How might administration help them? To recognize this is an issue, to empathize and show concern, to allow physicians input into what they're feeling, so maybe you can do something about leadership responsiveness, and I'll talk about these specifically later. Administrative support, ways to provide clinical support, way to provide emotional support, way to provide career support, but also thank them for what they're doing. The organizations, if everybody's happier and more successful and more productive, you have a better overall hospital culture or organizational culture and morale. Your reputation is better. It's easier to do recruitment and retention. You achieve your objectives, whether it's complying with metrics, which have a pay-for-performance type of attachment. There's less disruption, better productivity, better communication, more conflict resolution, better quality of care, better behaviors, better patient and staff satisfaction, and physician satisfaction. So it's not just physicians. It's as well known in nurses as well. And for nurses, it's similar type of stimulating circumstances, but there are some others. There's more and more involvement from compassion fatigue. Taking care of patients and taking care of patients, and sometimes not having the outcome that you would really like and dealing with that emotional exhaustion. Nurses may be concerned about changes in staffing and scheduling. They too are concerned about changing roles and responsibilities. I think most of us, at least in the older generation, are still really interested in the face-to-face, hands-on value of touching somebody and making eye-to-eye contact. And when you're spending less time doing that, you feel like you're not really doing your job to the best that you can. Certainly in nurses, there may be issues around gender bias and harassment, and there may be issues around disrespect and incivility. Then there's a recent, this just came out in April in the New England Journal of Medicine, where they had a roundtable discussion. They look at stress and burnout and how serious it is in nurses. Oh, this slide is, oh yeah, it is up there, good. It's not in your handout, but it's up here. They look at stress and burnout in nurses, in nurse practitioners, in clinical leaders, and in executives. And then recently, almost 3/4 of healthcare leaders feel some degree of burnout, survey finds. So it is sort of a ubiquitous type of problem, but for those who are doing the hands-on care delivery, which it affects the patients, that's where it can have the greatest repercussions. So what are you going to do? Well, in order to do something, you need to understand why people think and behave the way they do. It's almost like Psychology 101. So I'm just quickly going to go through all these. These are lectures. Each one is a lecture by itself. I'm going to talk about some of the internal factors that affect the way people think and process and behave, and external processes. The internal processes are deep-seated and maybe more difficult to deal with. Doesn't mean you can't. And the external processes are the ones that are more malleable to some type of adjustment. So let's look at the internal factors. First, there's certain issues about attitudes, about age and generation. The millenniums think and act differently than the veterans and the baby boomers. There's nothing right or wrong with that. It's just the way people do business, and you need to understand what their values are and reach a happy medium. Again, age and generation is a whole discussion by itself. The second thing is gender issues. It's not only gender issues about male or female, it's issues around the way you're respected, the way you're treated with a hierarchy, whether or not there's any harassment. Then there's a whole thing around culture and ethnicity. Different cultures have different values, different ways to communicate. You really need to understand that. The better you understand that, the better your end result. And then certainly all these issues can compound into what a person's personality is, and you can do personality testing. Now here's a pie graph of all the things that you could do as an organization to help individuals. So it's emotional intelligence, and I'll get back to that in a second, conflict management, communication skills training, diversity training, stress anger management, improving culture, behavior modification, courses on customer satisfaction. Emotional intelligence is getting individuals to have a better understanding who they are, what their internal or subconscious biases are, what their attitudes are, so you understand yourself and what the trigger points are, and at the same time to get a better understanding of what's going through the mind of the person you're dealing with, patient, family, nurse, administrator, peer, other. And then understanding you and understanding them, how do you get a better way to make ends meet so that everybody is satisfied? So this whole idea of emotional intelligence is a new type of training that gives individuals introspection and then strategies to help going forward. These are the external factors, particularly it may be the same in pharmacy and nursing, but it's certainly true in medicine. The training program certainly elicits certain types of feelings and behaviors, certainly healthcare inform, and then lastly, what we're going to talk about is stress and burnout. So in the training programs, at least when I trained, and I imagine many of you still, it's like a fraternity. It's a hazing type of environment. You don't know anything, don't speak, go to the books, practice your technology, do what you can to survive in this type of hectic environment. And as a result of that type of training, you become autonomous, you become very independent. What you do is you do things on your own, and it leads to issues related to a focus on technical and knowledge expertise, but certainly not a focus on personal and skill developing relationships, and I'll talk about that in a minute. Healthcare reform, and we're all living through this. It's people looking over our shoulder, telling us what we need to do it quicker, do it faster, don't do this. And we're going to look at the metrics, which many of us don't feel truly represent quality of care. And then a lot of your reimbursement is going to be based on those type of metrics. Excuse me. This is just a couple of articles in here to talk about how prevalent stress and burnout is in medical students. It is a serious issue. It affects them later in life, but it also affects dropout and also the rates of suicide. So it's a big issue, and luckily now, a lot of the medical schools are beginning to recognize what's going on. So they're doing a couple of things. One is they're changing the MCAT exams, the medical college admission test, to have more questions on philosophy, sociology, and psychology, just not math and science. They're looking for people who graduate with a more well-rounded major, so not necessarily math and science. Maybe your major is religion, maybe your major is psychology. And also, when they're coming into medical school now, they're beginning to pair them with nurses, with physical therapists, with pharmacists, and with others, so you get a better understanding of what everybody's roles and responsibilities are, and this starts out in the very beginning, plus teaching some of these emotional intelligence type courses during the actual part of the medical school curriculum. Healthcare reform, I'm not sure what we can do. This just came out September 21st on the survey, and it asked the physicians to rank Trump on healthcare reform. It didn't do very well. Stress and burnout. Okay, so this is these are one of the things, one of those items that we may have an opportunity to do something more about. I put over here organization and individual. This can't succeed with one physician, one nurse, one pharmacist, one therapist saying, I'm going to do it. I'm going to take care of myself. It has to be organizationally based. And 80% of success in reducing stress and burnout is at the organizational level rather than the individual level. So these are the 10 recommendations I'm going to go through. One is to raise awareness. How do you do that? To set it as a priority, to motivate people to take action. 2 is the importance of the organizational culture. 3 is to provide education. 4 is to provide relationship training. 5 is to provide logistical support, clinical support, behavioral support. And then I'll finish up what you can do to promote physician well-being, physician satisfaction, physician engagement. This is also applicable to pharmacists and others in the audience besides physicians. So the first thing to do is to raise levels of awareness. There used to be an issue called the triple aim. This comes from IHI, the Institute of Healthcare Improvement, which is probably the most prestigious quality organization in the States. The first 3 caveats of the triple aim were patient experience, population health, and reduced cost. And now they've added a 4th component on provider health. We need to take better care of our healthcare providers. One way you do that on the right is difficult to visualize is the Maslow survey. Dr. Mazak is from Berkeley in Northern California. This is an instrument where you can go ahead and assess the degree of stress and burnout and satisfaction in your staff. I'm sorry. Oh, wrong mic. And then most recently, the AMA has introduced the MERE survey. And I'm going to give you a web address for the AMA when I talk about other outside agencies that will help you achieve what you're trying to help. And this is something you can actually take on your own. So first thing is do an assessment. Unless you do an assessment, you'll never know what the status is, and therefore you'll probably not recognize what a problem it is and the need to do something about it. The second thing is to establish this as a priority. You know, as clinicians, stress and burnout, besides our own individual health, can affect our patient health or our staff health. But the idea is now maybe this is something that we all need to take into consideration. So a lot of these articles are focusing on an epidemic of stress and burnout throughout the healthcare societies. Purpose and motivation. Again, a lot of this is coming from the Mayo Clinic and from JAMA, as you can see here. It's really, we need to take a step backwards and try to recognize what we went into medicine for and the response that we get when we try to help people. So the whole idea is reinstilling the importance of joy and happiness in medicine. And probably the two biggest ways, and I'll talk about this briefly, is mindfulness and resiliency type of training. But as you'll see later on, there is a direct correlation between satisfaction, happiness, better communication and collaboration, and better patient care. Culture and leadership. As I said, this is at least 80% of the solution potential. And again, the Mayo Clinic is one of the leading organizations that's published on all of this, the importance of culture and resource support and empathy to understand what's going on in your professional population and doing something about it. And these are the caveats. This is a great, great article for anybody who really wants to get into it. The caveats that they talk about is the organization needs to acknowledge this as an issue. They need to understand the issue. They need to cultivate physician and executive champions who really are respected peer individuals who could talk about what this is. They need to provide incentives to help people. They need to improve the culture. You need to align the goal. You know, there's one thing with economics and financial viability compared to quality of patient care, but the mutual goal is we're in the business of best patient care and remind and incentivize and provide programs that support that. We need to provide the appropriate interventions and support, which I'll talk about in a few minutes. We need to promote a strong work-life balance, promote self-care, and then lastly, enhance overall physician engagement. So why would the organization do this? Because there's a big, I mean, you do want to do it for best patient care, but sometimes when you're looking at a balance sheet, maybe that's not what you're thinking. So the whole idea is, and this is a great article that came out in JAMA on the business case for investing in physician well-being. And again, this is, can't read it here, but it's probably just 2 or 3 months old. But the costs of turnover, the cost of recruitment, the cost of hiring a new physician, getting that physician on board is probably close to $1 million. The cost of unhappy, poor communicative, poor relationship, poor team collaboration can have a negative effect on productivity and efficiency. And of course, when you're getting reimbursed by the matrix, whether it's pay for quality or subtraction of pay for poor quality or adverse events and readmissions, pay for HCAHPS and satisfaction scores, pay for cost efficiency. Most hours are fixed hours. If you're more, I used to be a medical director for the insurance company, there's a better way to do things, a more efficient way to do things, and that will actually save money with fixed dollar reimbursement. So there definitely is an ROI on doing this, and sometimes you have to remind individuals. The examples I put on the bottom are probably some of the premier organizations that have handled this. Mayo, Brigham, Stanford, Geisinger Clinic, Johns Hopkins, Oregon, Cleveland Clinic, and others. Education and relationship training. General education is basically what I'm doing right now, just trying to highlight how serious an issue it is and the call to action. But the relationship types of training I put in here, it's everything from simplistic phone etiquette to diversity training, communication, teams training, enhancing leadership skill development, conflict management, and so on and so forth. Staff support. So I break up staff support into three issues. And now we're really getting into the nitty-gritty of what really can be done, although certainly the relationship training can be done. Administrative, clinical, and emotional. Administrative. If the physicians and others are getting bummed out by scheduling, by doing all this on-call responsibility, by participating in all these committees, maybe you want to revisit their scheduling. Maybe you want to revisit their capacity management and give them time to do what they need to do. What I always hear about is physicians don't have enough time. They're taking their charts at home and they're doing homework all the time, which of course is not a very positive influence on life balance. So maybe there's something the organization needs to do from a scheduling, capacity management type of perspective. A lot of organizations are beginning to offer clerical assistance. One of the biggest concerns about physicians, of course, is the time spent in the electronic medical record. So maybe with the use of scribes, people who help you do the input will leave some of that task-oriented problems to somebody else, and the physician can spend more time on complex medical issues. Some organizations have actually hired a personal assistant to help a physician, not just a scribe. System redesign and simplification. How do you improve process flow? How do you improve the adaptability of the computer? There's a whole bunch of different things that are institution specific. And in some cases, financial support, particularly for the younger physicians coming out, helping them with some of their financial concerns. From a clinical perspective, there's been some great resources that talk about the advantages of using physician assistants and nurse practitioners. And again, organizations are now providing care coordinators, either in the office or assigned to an individual physician. It's like a care liaison that all the other things, from getting their appointments, getting them into placement, this can be done by different types of individuals. Sometimes they've been called navigators. Emotional behavioral support. Certainly supporting wellness activities, and I'll talk about relaxation and mindfulness. Providing courses on stress management and resilience training. EAP is an employee assistance program. I used to be a medical director for physician wellness services, which was an employees assistance program that was specific to physicians. So it was confidential. It was physician-to-physician interaction, originally by phone, because they're located actually in Minneapolis. But if necessary, one-on-one interactions in person. The idea is we'll make it convenient for you, we'll do it confidentially, and we're here to try to help you succeed as being a good, practicing, successful physician. Other types of counseling and therapy, behavioral intervention. Some states have physician health programs, and then certainly helping with career management. I'll talk a little bit about some of these more as we go through. Stress management, it's sort of common sense, what you think. Getting some of the problems, getting physicians to really understand, because as I said before, they're used to all this, and they don't look at the signs of what it's doing to them. Understand the importance, consider consequences, promoting taking care of yourself, which means a little bit of introspection, get a look at life, acknowledge your symptoms, recognize what you really want to do, be able to say no. Avoid stressful situations, get enough sleep, good nutrition, good exercise, relaxation, and meditation. The issue is they need to think about it, but they need to schedule it, otherwise many times they won't do it, or the organization needs to reinforce time off for doing these types of programs. Be willing to accept advice. The idea is we want to help you. You are a precious resource. There's no downside ramifications. And we're here to try to help you do what you need to do. And if necessary, we need to change the situation, we'll change the situation. Mindfulness training, again, this is a full-day course. But the whole idea is to remind people why they're doing what they're doing. So a lot of this is self-reflection, even during all the chaos. And then to really to think about one or two positive things that have gone on during the day. That's the way you want to end it. God, I had to spend 45 minutes with this patient, and now I can only have to spend 10 minutes with this patient. But you know what? During that 45 minutes, I really helped that patient understand and get to the point where they really need to get to. So think about the positive things of what you're doing and try to have that sort of supersede all of the negative types of things that are going on. Typical mindful practices are meditation, reflection, stress reduction, thoughts, choices, priorities. That's getting back to the idea of setting time aside and being able to say no. Resiliency training. The idea of resiliency training is to teach you coping skills in the heat of battle. So it used to be just, take a breath and count to 10. But there's other ways of improving resiliency to try to effervesce the problems with a stressful situation. And a part of it is really self-awareness and then teaching certain tools and strategies to help you reduce the stress during that moment. The focus is on recognition, acceptance, teaching coping mechanisms, situation management, maintain a positive focus, maintain well-being. Some people talk about true grit. Behavioral support. There can always be informal behavioral support. One of the things is it's okay to talk to other people about it. In fact, that's when we talk about physician engagement, that's the number one step. Let people talk about what's going on in their world, be receptive and listen. So informally, you can talk to your partner. Maybe informally, you could talk to your director. Maybe informally, you can talk to the pharmacist, talk to the nurse, talk to the administrator, just an informal type of conversation. Many organizations have a physician wellness committee. There is no one diagram that will satisfy what a physician wellness committee should be. Physician wellness committees in the past, they were made up of a bunch of different specialties, some contributions from human resources, from administration, nursing, physicians, others, depending on the organization. And it used to be, we'll put on a quarterly program on the importance of good nutrition, a quarterly program on how to sleep better, quarterly program on how to exercise better. Now the physician, a lot of more progressive physician wellness committees, actually have representatives on the committee who can actually interact with somebody. In most cases it's a physician, maybe others. This is not through an EAP. It's through the Physician Wellness Committee. The point is, the person who's on that committee who's doing the action really needs to be trained appropriately of how you deal with the physician who's going through all of this. So a lot of times, physicians respect other physicians, so if you can cultivate a physician and cultivate that skill set, and that you can now enhance something that's more appropriate to coaching and counseling through your Physician Wellness Committee. The Employee Assistance Program, again, there's either physician-specific or not physician-specific. Remember the barriers I talked about with physicians using these types of programs. Sometimes you can have help from human resources. Maybe they can act as coaches. You can provide some of the... There's training programs. We talked about mindfulness, resiliency, diversity, conflict management, stress management. And then coaching. Coaching has now become a very popular type of strategy because it works. Having somebody who's well-trained meet with the individual, physician or not, just talk about them and give them some suggestions of how they can better handle the situation. The three caveats are, it's confidential. We're here to help you succeed in practice. It's not that administration is telling me you need to do this. And three is, we'll do it through a schedule that's convenient for you. When you have problems with behavioral issues, you need to do counseling. You can't let disruptive individuals just run through and disturb everybody. We really need to address that type of issue, do the appropriate behavioral intervention. Here are the outside resources coming up in the next slides. There's three big national medical societies that provide fantastic resources. The first one is the AMA Steps Forward program. preventing physician burnout, improving physician resiliency, preventing resident and fellow burnout. On the bottom is the web address. A lot of the stuff you can do on your own, so just sitting at your own laptop at home at your convenient time for you. The IHI, again, the Institute of Healthcare Improvement, has a great program. A lot of this is focused on turning burnout into engagement. They talk about improving joy and happiness in physicians. The third one is the National Academy of Medicine. And again, all of these are readily available to you. And the idea is they really want to take very prestigious groups together to provide recommended steps that individuals can look at to improve their well-being and resilience. Physician well-being. We really need to take care of ourselves, and sometimes somebody else has to make us realize that. So we need to understand the importance of being well. We need to consider the consequences of not being well, and then we need to take care of ourselves. So part of it is saying no, and part of it is having allotted time for doing it, either mandated by the organization or mandated by yourself. But the idea is to promote rest and relaxation. Be willing to accept and receive outside support. Recognize that the intention is to help you. It's confidential. It's not here in any punitive manner. And in some cases, if necessary, maybe we really do need to change your situation. Now, continuing with well-being, there's through the Collaborative for Healing and Renewal in Medicine, and again, this just came out in JAMA, there's groups of individuals from across the country, and this is not just healthcare professionals, it's psychologists and others that have sat around and talked about how important physician well-being is, and they've come up with these lists of strategies. They're broken up into societal comments, foster a trustworthy and supportive culture, advocate for policies that enhance well-being, organizational commitments. We talked about interpersonal and individual commitments, and the guiding principles are effective care promotes and requires physician well-being. Physician well-being is a quality marker. Physician well-being is a shared responsibility. Thank you. Dr. Shanavelt and Dr. Stinsky and Dr. Dybee are probably the three leading authors across the world who really focus on this. Dr. Shanavelt was originally in the Mayo Clinic. He supported a lot of those Mayo Clinic proceedings. He eventually was recruited over to Stanford and now is the first chief medical officer in the world. So Stanford has now created a position as the chief medical officer. And what Stanford is also doing now, they recognize how important this is. They're now offering a course on chief wellness officer development. So I put that information in here. Additional services. What else can an organization do? Provide access to healthy food and beverages. Provide training in mindful eating. Provide on-site exercise facilities, provide on-site showers, provide convenient opportunities for mindfulness and yoga and relaxation exercises. Establish a quiet, refresh and recharge room. One of the things that you hear about, some organizations, let me back up a little bit. With hospitals now and intensivists, a lot of physicians are not spending as much time in the hospital. They lose that camaraderie in the physician's lounge. What you really want to do is to provide a room or a space where physicians and others can actually get together and talk about certain things. So this idea of a quiet, refresh and recharge room is now getting a lot of support. Provide peer support for physicians trained to listen to their peers, financial counseling, provide after-hours support, and at the very bottom, in some organizations, they'll actually provide child care for you, they'll provide laundry services, they'll provide gourmet meals. I mean, use your creativity and find out what kind of amenities you can give a really hectic, chaotic, overworked physician an opportunity to actually feel a little bit better.
I did actually what was in our...
Joy and satisfaction. Again, I talked about how important it is to reinvigorate medicine. Joy in practice, clinical satisfaction, and a healthy workplace trial. is a lot of documentation supporting the work done to enhance joy and happiness, what it does to the individual and what it does to the outcome. This is not in your package. I just got it in my email today. If anybody wants this, just email me. But there's as I mentioned, Dr. Christine Sinsky is one of the three of the most prominent speakers or educators. She is putting on a symposium called Joy in Medicine. It's sponsored by MMIC. You can look them up. It's free, but it's occurring on October 10th. So if you can't get it through MMIC, just email me, and then I will send you the link. But the whole idea is, I'll just read the description. Professional satisfaction is a powerful driver of quality of care, the patient experience, and wise resource use. And as a result, is of critical importance to healthcare system leaders and practicing physicians and alike. Improvements in clinical workflow, teamwork, and leadership communication are among the most important antidotes to burnout. So it just supports all the things that we're talking about. So if you need that, just get in touch with me. Just finishing up in the last couple of minutes, we'll open up for a question. Physician engagement. And again, it's not just physicians, it's all healthcare professionals. You want them to be to discuss and do something about it. You're not going to solve all the problems, but giving somebody an opportunity to vent makes them feel respected, gets them engaged. Engagement leads to more joy, more quality, more satisfaction, more positive well-being. So in the last slide, these are just an accumulation of all the solutions. Recognize the seriousness and the significance of the issue. Set physician well-being as a priority. It said in the very beginning, healthcare providers are a precious resource. They're working under extremely stressful conditions. Raise organization and individual awareness and accountability. A lot of it has to do with organizational culture and leadership support. Show empathy. Listen, solicit input, either by meetings or by surveys, discussion groups. Respond to the issues. Motivate action, address the barriers. Remember, barriers are particularly important. It doesn't have to be the stoic fear of repercussions. I don't have the time to do this. I'm so busy doing this other stuff. Foster projects, champions, and collaborative support. Proactive support. Recognize the reluctance to act. Provide the administrative, logistical, and clinical support we talked about, the training, the behavioral support. And lastly, never forget to take a moment out to recognize, motivate, engage, and reward. Nothing works better than listening to somebody and saying thank you for all the work you do. It's more than just stress management. Okay, so now what I'll do is I'll open it up for questions if anybody has any. Yes, in the back.
My name is Dr. Caballero. And on this physician burnout, there is any study that relate that problem with the excessive documentation with the EMRs and the time we spend in EMRs. I see in that solution list that nobody's doing that over-documentation and the obsession of the government with details that are unnecessary. So
Okay.
the physician are spending 25% to 50% of the time in the computers, which is supposed to be pretty much the God of healthcare. So there is any link to that?
Thank you. Just to repeat the question, most of the focus was on the frustrations that and the time physicians are spending on the electronic medical record. I certainly agree with you. That's probably the most common concern when you look at the stress-related factors. Unfortunately, because it's a government mandate, the electronic medical record is pretty much here to stay, but how do we get physicians and others to better adapt to it? And there's no easy solution. One way is to understand it's not going to go away. So how can we have you better comply? More training, more individualized training, more clerical support by the way of use of scribes and so on and so forth, and making the computer system, this is where it gets a little more difficult, making the computer system user-friendly. So it's going to take a computer engineer to actually sit down with physicians to try to create a better process. It's very difficult. It's not going to go away. It's a matter of trying to work together and pacify some of the concerns, but the organization really needs to make that effort to understand how important it is and do something about it. Yes?
There is also studies that are looking at the increase of depression, not just among people who stay in front of the computer all the time. They call it the blue depression, just by looking at the screen. It's a life that is so natural for not for physicians, for anybody. And we're spending easily 6, 7 hours.
No, good point.
That can be a solution that can help with that easily.
The question was raised that was called blue depression. The idea is you're looking at a screen for so long that it leads to physical depression. It's not unique to physicians, it's not unique to computers. If you have children, you know what the situation is. There's no real solution other than, one, recognize that this is an issue, do something to break eye contact with the screen so you can get back to, a non-screen life. And then, again, through the process engineers, to try to minimize the actual amount that you have on the screen. So it's a combination effort. Any other questions? Okay, thank you, everybody, for taking time. I'm always happy to talk to people. You can either catch me now, or if you want to email me, I'm happy to talk to you either by email or by phone. It's just a very important issue. A lot of the times, it's very important to get the organization who have the capacity to control the resources to recognize how important this is and to actually do something about it. So try to go out and spread the word. Okay, thank you, everybody.